Assalamu alaikum wa rahmatullah. Today we will complete our talk on the female reproductive system. In the last lecture, we have described the ovarian cycle. Today we will describe the endometrial cycle, which is the changes that take place in the endometrium of the uterus of the female that are uninfluenced by the changes in the ovarian function and the fluctuations of the hormones released by the ovaries. So the objectives of this lecture are going to be to describe the normal menstrual cycle and to discuss the structural changes that take place in the endometrium during the menstrual cycle, and explain the hormonal control of these changes. Then you have to recognize the phases of the menstrual cycle and the physiology of menopause and some of the disorders of menstruation or ovulation. Now, before starting our discussion on the menstrual cycle of the female reproductive system, let's talk about the effects of the main hormones of the female sex hormones, which are estrogen and progesterone. The main and primary function of estrogen is to induce cellular proliferation as well as growth of the tissues of the female sex organs and other tissues that are related to reproduction. Estrogen induces growth of the female sex organs. They increase in size several times. And estrogen also has a marked effect inducing proliferation of the endometrial stroma and glands, which will provide nutrition to the ovum, the implanted ovum. Also, estrogen has similar effects in proliferation of the stroma and glands of the fallopian tube, as well as increasing the number of ciliated epithelial cells that will enhance the transport of the fertilized ovum in the direction of the uterus. Estrogen also has a significant effect on breast development and growth of stromal and ductile system, as well as deposition of fat. The effects of estrogen on the lobules and alveoli of the breast are slight, but the effect of progesterone and prolactin they have the ultimate role in the growth and function of these structures. Estrogen has also an important effect on the skeleton. It inhibits the osteoclastic activity of the bones and thus stimulate bone growth. However, they can cause union of the epiphyses with the shaft of the long bones, and that's why female actually their growth or their increase in length ceases earlier than in males. The effect of estrogen on skeleton is noticed after menopause. When estrogen levels are declined progressively, then there are high chances of having osteoporosis, which is induced by estrogen deficiency. And actually, there might be the use of estrogen replacement can be prophylactic in this situation. In addition, estrogen has a slight effect increasing the protein deposition, and mainly due to the enhancement of growth of the female sexual organs and bones. However, testosterone has more general and more powerful effect than estrogen in this regard. Estrogen increase body metabolism rate, and to a slight extent, and it's only 1/3 as much as does testosterone affect body mass, body metabolism. And estrogen also has a significant effect increasing fat deposition in females, and that's why females has more fat distribution than males, and that affects the fluid percentage in females. It's a little bit less than the fluid percentage in males. Also, estrogen has little effect on hair distribution. They actually don't greatly affect hair distribution, but the adrenal androgens that increase after puberty, they have greater effect on female hair after puberty. Estrogen has an effect on skin. Skin of females after puberty become softer and smoother, but it still will be thicker than during childhood. And there is also an effect on the vascularization of the skin, which gets more vascularized, and this is associated with increased warmth of the skin and increases the bleeding if the skin was cut than it is observed in men. Estrogen also has an effect on electrolyte balance because they are similar to aldosterone in structures and other adrenocortical hormones. They have this effect, they share this effect, which they all cause sodium and water retention by the kidney tubules in the nephrons. And that is actually more significant during pregnancy due to the tremendous amounts of estrogen secreted by the placenta during pregnancy. Now let's talk about the effects of the second important female sex hormone, which is progesterone. Progesterone effects are very important in the secretory changes in the uterus during the second half of the female cycle, which is the luteal phase. And this actually prepares the uterus for the implantation of the fertilized ovum. In addition, progesterone decreases the frequency and intensity of uterine contractions. Thereby, they help them prevent the explosion of the implanted ovum. This is important for the conception. Progesterone has also an effect on the fallopian tubules, promoting more secretory actions or activities by the fallopian tubules. And actually, these secretions are necessary to provide nutrition to the fertilized and dividing ovum. Finally, progesterone promotes the development of breasts. As we mentioned earlier, it has a significant effect on the proliferation of the lobules, specifically the lobules and the alveoli of the breasts. And it makes them become secretory. However, progesterone does not cause these structures to produce and secrete milk. Instead, the hormone prolactin does that. Progesterone also causes the breasts to swell due to the secretory actions and due to fluid deposition. The uterine or endometrial cycle, we will have first the proliferative phase, which is called the estrogen phase. And the second phase is going to be the secretory phase, which is called progestational phase. And the proliferative phase actually is parallel to the pre-ovulatory phase in the ovarian cycle, while the secretory phase is parallel to the post-ovulatory phase of the menstrual cycle. And in the middle, we have the ovulation event as it occurs in the ovarian cycle. So in the proliferative phase, which we call estrogen phase, in the beginning of each cycle, most of the endometrium has already been desquamated and by menstruation. Okay, so this lining, the stroma, most of the stroma is going to be desquamated, but only a thin layer of the endometrial stroma will remain, as well as the deeper portions of the glands and crypts of the endometrium will remain. And as we already knew that the growth of these stroma, endometrial stroma and glands are due to the influence of estrogen in the previous cycle, then at this phase, estrogen and increased level of estrogen will be increased and will induce the growth, stromal growth, and epithelial cells will proliferate rapidly. So this endometrial surface will re-epithelialize within 4 to 7 days after the start of the menstruation. So that before ovulation, the thickness of the endometrium is going to be increased due to the increased number of stromal cells and progressive growth of the glands, as well as the new blood vessels. So as you can see here in this figure demonstrating the different phases of the endometrial cycle, in the proliferative phase, we have the progressive increase in the thickness of the endometrium. And in the secretory phase, we will see also at the time of the ovulation, the thickness of the endometrium is about 3 to 5 millimeter. The endometrial glands and the cervical region will secrete the thin stringy mucus, which actually helps to guide the sperms in the proper direction toward the uterus. So after ovulation, the secretion of progesterone and estrogen are going to be increased as part of the luteal phase of the ovarian cycle. So estrogen causes slight proliferation in the endometrium at this point. However, progesterone will cause a marked increase in swelling and secretions from the endometrium. Actually, the glands will be more tortuous, and there will be increase in the secretory substances that will accumulate in these glands. That's why we call this phase as the secretory phase and the progestational phase. The stromal cells cytoplasm will increase lipid and glycogen deposition, and also blood supply will increase to the endometrium, which they become more tortuous. And 1 week after ovulation, the endometrium thickness is about 5 to 6 millimeters. The secretory changes prepare the endometrium to store nutrients that are necessary for the growth of the fertilized ovum. And the uterine secretions are also called uterine milk, which provide nourishment to the dividing ovum. The trophoblastic cells on the surface of the implanted ovum begin to digest the endometrium and then absorb these stored substances, and that's how they get the nutrients in the glands and in the lining of the endometrium. The last phase or stage of the endometrial cycle is the menstruation phase. So if the ovum was not fertilized and about 2 days before the end of the monthly cycle, the corpus luteum, we know that it will be involute and the ovarian hormones will decline to a very low levels. And actually that will start necrosis in the endometrial blood vessels due to different factors. First, vasospasm of the blood vessels, decrease of the nutrients that are coming to the endometrium, as well as loss of the hormonal stimulation. As we said, estrogen and progesterone levels are going to decline, are declined at this stage. So there will be a desquamation of the tissues and blood, plus there will be contractile effects of prostaglandins that will all initiate contractions which help to expel the desquamated tissues and blood vessels from the uterus. In normal menstruation, about 40 mL of blood as well as 35 mL of serous fluid are going to be lost. The menstrual blood is normally non-clotting, and that's due to the presence of fibrinolysin. This is a very important note, because if there was any clots in the menstrual blood, that indicates pathology, and that may indicate that volumes of lost blood are increased and that fibrinolysin was not sufficient to prevent clotting. Within 4 to 7 days after menstruation, the loss of blood will cease and the endometrium will start epithelialization. Leukorrhea during menstruation is a characteristic where leukocytes will be released with the necrotic material. So the blood of the in the uterus at this stage will be highly resistant to infection during menstruation as a kind of protective mechanism because of the desquamation and bleeding. Now, let's summarize both endometrial and ovarian cycle in this graph. As you can see, the ovarian cycle is parallel to the endometrial cycle, and the oscillating levels that of hormones secreted by the ovaries will induce changes in the endometrium, and that's what causes the uterine or the endometrial cycle. That in the pre-ovulatory phase, we will have the proliferative phase in the uterus, and after ovulation and or post-ovulatory phase of the ovarian cycle will be parallel to the secretory phase, and at the end of that we will have the menstrual phase at the beginning of the new cycle or ovarian cycle. So estrogen is the main hormone that will induce the endometrial proliferation at the proliferative phase. However, in the secretory phase, progesterone will be the hormone that is responsible for the secretory function of the lining or endometrial lining at this stage. Loss of the ovarian hormones will start the menstrual phase, and that's where menstruation starts, and a new beginning of the ovarian cycle as well as the uterine cycle will start at this point. Now let's talk about menopause and disorders some of the disorders of when both ovarian and endometrial cycles cease and ovulation fails to occur, okay, which we called an ovulatory cycle, then the menopause stage or period of female life will start, which occurs at about 40 to 50 years old. There will be loss of estrogen. A sudden loss of estrogen at the beginning of menopause will cause marked physiological changes in the function of the body, which include hot flashes characterized by extreme flushing of the skin. Also, there will be some psychic sensations and dyspnea. There will be increase in the irritability, nervousness, anxiety, fatigue, and occasionally some psychotic states, and decreased strength, as well as the calcification of bones, which may increase the risk of having osteoporosis in the future. The figure on the top represents total rates of gonadotropic hormones secretion in the urine on the y-axis, and that's during different stages of the sexual lives of male and females. As you can see here, male is indicated by the blue line, and in females is indicated by the red line. Before puberty, in both males and females, the levels are very low, as indicated here in the curves. However, after puberty, there will be increase in the levels of gonadotropic releasing hormones in the urine, and that's in both females and males after puberty. However, after the age of menopause, or after the start or onset of menopause in females, there will be a sudden increase in these levels and later also. And that's because of the loss of the negative feedback effects of estrogen and progesterone due to the loss of these hormones after menopause. However, in males, we will not see this. Actually, gonadotropin releasing hormone is increased slightly to later ages. And that's because testosterone levels will be high enough not to induce that negative feedback that is seen in females when estrogen and progesterone are completely lost after the cessation of the ovarian function. In the lower figure, you can see the relationship between age on the x-axis and the estrogen excreted in urine, and you can see the fluctuations after puberty. Before puberty, you know that estrogen levels are very low. After puberty, there will be this pattern of oscillation or fluctuations of the estrogen levels across the cycle, and we know these changes take place. However, after menopause, there will be an acute reduction and cessation of secretion of estrogen, and that's indicated here in the excreted estrogen in urine. As you can see here, when it's close to menopause, the fluctuations, durations are reduced to a large extent, and the excretion rates of estrogen declines progressively for a long time before menopause, as a preparation for the end of this stage, stage of reproductive age, to begin the menopause. One of the abnormalities of the ovaries can be hypogonadism, which is reduced secretion by the ovaries, can result from either poorly formed ovaries or lack of ovaries, or genetically abnormal ovaries that may secrete the wrong hormones, either because of missing enzymes in the secretory cells, or something wrong with the secretory mechanisms by these cells. When the ovaries are absent from birth, or if they were non-functional before puberty, then female eunuchism will occur. Hypersecretion of the ovaries is clinically rare because if the ovaries were secreting high amounts of the female sex hormones, then there will be inhibition of the gonadotropic releasing hormone, and then inhibition of the secretion of female sex hormones. However, if there were increased levels of the female sex hormones, that might be indicative of a tumor that is releasing these hormones. Some of the common disorders of menstruation are presented here. Amenorrhea is the absence of menstrual period, which can be either primary amenorrhea, in which menstrual bleeding has never occurred, or secondary amenorrhea, where cessation of cycles can happen with previously normal periods or after previously normal periods. And the main causes of secondary amenorrhea is pregnancy, which is the most common cause, or it could be due to emotional stress, hypothalamic disease that is associated with decreased pulses of gonadotropic releasing hormone, or some pituitary disorders, or it can be due to primary ovarian disorders and various systemic diseases. Menorrhagia refers to abnormally heavy or prolonged bleeding. Hypomenorrhea refers to scanty flow of menstrual bleeding, and dysmenorrhea refers to painful menstruation or cramps due to accumulation of prostaglandins, which can be treated by inhibitors of prostaglandin synthesis. So at this we finish our lectures on the female reproductive system before pregnancy, and then we will start with the female reproductive system after pregnancy. And thank you and good luck.